Hello, my name is Ravi Vij. I'm from My Cancer Haven, and today in the Conversation with Cancer Experts series, we have one of the leading myeloma experts in the country, Dr. Ashraf Badros. He is going to talk to us about a large phase 3 study that he just presented at the International Myeloma Symposium meeting in Brazil just literally 2 weeks ago. He's the first author of this study, and we are privileged to have him here today to discuss his findings. Welcome, Ashraf.
Oh, thank you. Thank you. Pleasure to be here.
So, Ashraf, can you just put in perspective, first of all, the background to this initiative, this study, and then we'll go over the data.
As you know, the standard of care for newly diagnosed myeloma is induction, consolidation with transplant, followed by lenalidomide maintenance. And recent trials like the Griffin and the Perseus trial, daratumumab was added to the Velcade Revlimid Dex induction, followed by maintenance daratumumab lenalidomide in the arm that received daratumumab for induction. And in these two trials, there was significant improvement in progression-free survival. In those trials, in the maintenance component of those trials, MRD negativity rate improved. And maybe to give a little bit of background, most of the MRD conversion occurs after the initial induction transplant and consolidation. In those trials, the patients that were MRD positive at the end of consolidation, 60% of them converted to MRD negative when they went on the daratumumab lenalidomide maintenance, which really shows that continuous treatment can improve the MRD negativity rate as time goes on. And of course, we know by now that MRD negativity is associated with improved long-term outcome. Many trials showed that MRD negativity is going to be a surrogate end marker for rapid acceleration of oncology drugs in myeloma. And we are hoping to show that MRD negativity is an adequate endpoint. And this is one of those trials that focused on MRD negativity. In this trial, we compared daratumumab lenalidomide maintenance versus lenalidomide maintenance alone. And this is the first trial to directly compare those combination or doublet, dara lenalidomide versus lenalidomide alone in a randomized fashion. I think you put the study design. And the trial was a multi-center. It was actually open in 50 centers across the US and Canada. Patients were randomized 1-to-1. They should have received a minimum of 4 induction cycles that did not include CD38 antibody, followed by transplant within 12 months. And at a screening, patients should have achieved the VGPR and were MRD positive by NGS or next generation sequence. So 3 requirements: no prior daratumumab, VGPR or better after transplant, and MRD positive. So it's a very selected subgroup of patients. Patients were stratified by cytogenetic risk and randomized within 6 months of the transplant date to go on dara lenalidomide versus lenalidomide alone. Treatment was given up to 36 months. After 36 months, it's up to the investigator. In general, if the patient was high risk, they stayed on the maintenance program. If they were standard risk and were MRD negative, most of the time, I personally stopped treatment and followed the patients. The MRD testing was done at 12, 18, 24, and 36 months. And the primary endpoint of the study was MRD negative conversion rate at 10 to the 5th after 12 months of maintenance. That's basically the trial design.
So what was the demographics of the patients you ended up with?
We ended up with what you expect to see in newly diagnosed patients. We have some unique features in our study. 20% of the patients were Black. And as you know, this is an underrepresented population in any clinical trial where the percentage is usually about 5%. But in our study, it was 20%, and that's due to many centers were from large African-American, mostly population like ours, and that allows us to enroll more Black patients. The other thing that I will mention about the demographics that you put up is the cytogenetic risk. The cytogenetic risk on this study was evaluated by two definitions. The standard definition include deletion 17, translocation 414 and 1416. The revised definition, in addition to that, included 1q gain and amplification and translocation 1420. The stratification was done both at diagnosis and at screening using the revised definition. When we did the analysis, we used the standard definition. So if you look at the revised definition, it was balanced, 32% versus 30%. But if you look at the analysis that we did using standard risk, you see that there is more high-risk patients in the daratumumab lenalidomide arm at 23% versus 16.9%. And most of that imbalance was delivered by higher percentage of deletion 17 in the DARA arm at 14% versus 3% in the lenalidomide arm. And just notice, this imbalance favored the control arm. And of course, patients received mostly VRD regimen, 80% of them. Others received CyBorD, KRD, and KCD. And 2/3 of the patients were in a VGPR at diagnosis.
So what about the primary endpoints? So what did you find?
So the primary endpoint is showed in the first graph on the left. All the patients completed 12 months of maintenance or discontinued treatment. The median follow-up was 32.3 months. Duration of treatment was 30 months for the DR arm and 20 months for the lenalidomide arm. And really the main primary endpoint was intent to treat. MRD negative conversion rate at 10 to the fifth at 12 months was in 50.5% in the DR arm versus 18% in the lenalidomide arm. And that difference was highly statistically significant. If you look at the middle two graphs, we show the higher rate of MRD conversion again at 12 months in patients who achieved a complete response or better at any time after randomization, and in patients who were MRD evaluable. And on the right, we show on graph the patient that achieved MRD negativity plus CR or better, which was higher for the DR arm at 44% versus 14% in the lenalidomide arm. And this is important endpoint because when the FDA requested approval or using MRD negativity, they wanted to add MRD negativity in patients who are CR as well. So the combined MRD negativity plus CR was 44% versus 14.9%.
How did the subsets of patients do?
The subgroup analysis showed consistent benefit in terms of MRD negativity, again favoring daratumumab Revlimid arm versus R alone, including older age, advanced stage, and high-risk cytogenetics. And actually in ASH, we are presenting an ad hoc analysis for the high-risk cytogenetics group, and it's accepted for oral presentation. So keep an eye on that.
Well, looking forward to it. So you also had more detailed analysis of MRD over time. So what can you tell us about this more detailed analysis?
If you look at the overall MRD conversion rate for the study, as I said, the median follow-up was about 32 months. It's 60% for the lenalidomide arm versus 27.7%. So it's more than doubled during the study duration. And you notice that the significance of that is with continuous treatment, you are getting more MRD negativity. So despite the fact we're looking at 12 months, we're still seeing more responses at 24 and 36 months. If you look at sustained MRD, which meaning MRD that lasted 6 months or more, it was 35% for the Dara Revlimid arm versus 13% for the Revlimid arm alone. That's the graph on the right. So the MRD negativity that is sustained is higher in the DR. And it's important to note that this will increase as time goes by and as more patients reach the 24 and 36 months. We expect to see increase in the number of sustained MRD negativity.
And what about at an even deeper level of MRD?
At MRD 10 to the 6, which is 1 in a million, Similar trend to what you have seen at 10 to the fifth. On the left graph was intent to treat. DARA Revlimid quadrupled the MRD negative conversion rate by 12 months at 23 versus 5%. And on the right, it's what tripled the overall MRD after randomization at 36 months versus 12.9 months. So again, clear benefit for the addition of daratumumab to lenalidomide.
And obviously, MRD was the primary endpoint, but then there were conventional responses also adjudicated. So, what can you tell us about responses and complete responses?
As you see on the graph on the left, the CR or better was 74 or almost 75% versus 61%, favoring DARA lenalidomide. And on the pie chart, we are only looking at the patients who entered the study in VGPR. And again, CR or better was 66% versus 45%. So it's clear that addition of daratumumab deepened the response with MRD negative conversion and improved the CR or better rate.
And what about progression-free survival?
At a median follow-up of about 32 months, again, PFS favored DARA lenalidomide with 47% reduction in the risk of progression or death versus lenalidomide arm. That's a hazard ratio of 0.53. Estimated 30 months PFS was 82.7% for DR versus 66% for R alone arm. You will notice at the end of the graph that after the study was stopped, study stopped at 36 months, but there were two events that occurred beyond 36 months with sharp drop in the Kaplan-Meier curve. I just want to say that those two patients were high-risk patients. Both of them stopped DARA lenalidomide maintenance and very quickly relapsed. It's not enough to recommend continuation of treatment, but we know that MRD negativity in high-risk patients might not be a good guide to stop treatment. And most clinical trials now, if the patient achieves MRD negativity and they're high risk, you leave them on the treatment. You don't stop it, because when you stop it, you relapse very quickly. And the hazard ratio really summarizes the magnitude of difference between the two curves, and it's 0.53, which is a more accurate measure of PFS benefit as it compares the entire time on the study in both arms, and it clearly favors the DR arm.
And what about analysis of progression based on the level of MRD attained?
So PFS benefit was observed among patients who achieved MRD negativity irrespective of how they reached that. So if you achieved MRD negativity on lenalidomide or on DARA lenalidomide, you have identical PFS. 30 months PFS was 95% versus 94%. If you are MRD positive, you are 69% for DR or 59% for lenalidomide arm. So clearly, achieving MRD negativity, whether with lenalidomide alone or with DARA lenalidomide, the benefit is there. What is unique about our study is the higher rate of MRD negative conversion for the DR arm, again, showing overall improvement in long-term outcome for the whole population. But for individual patients, if you achieve MRD negativity, you will do well, whether you go on lenalidomide or lenalidomide daratumumab at 12 months.
What about the side effects?
Side effects were high. Almost every patient has some side effect, and that's very much expected. But the serious adverse events were higher in the DR arm. DARA has 30% serious adverse events versus 22% in the lenalidomide arm. The most common were grade 3 and 4 cytopenia, mostly neutropenia at 54%, and infections, which was 18.8% in the DR arm versus 13.3% in the R arm. It's also worth noting that this trial was done in the COVID era, and we had almost a quarter of the patients were infected with COVID, but only 1% in the DARA arm and 3% in the LEN arm had grade 3 or 4. Discontinuation of treatment related to adverse events were also higher in the DARA arm compared to lenalidomide alone arm at 14.6% versus 8.2%. And I think the rate of higher side effects and the stopping of treatment was related to the longer treatment duration on the DARA Revlimid arm. 30 months versus 20 months for lenalidomide alone arm. So patients stayed almost a year longer on the DARA arm, which lead to longer drug exposure and increased reporting of side effects on the DARA Revlimid arm.
So, what are the major takeaways that you would like the audience to have from this presentation?
I think that if you have a newly diagnosed myeloma patient who were anti-CD38 naive, in VGPR or better, and MRD positive after transplant, daratumumab lenalidomide maintenance resulted in significant improvement in MRD negative conversion rate, improvement in MRD conversion rate in all clinical subgroups, including high-risk patients. There was almost doubling of sustained MRD favoring DARA Revlimid. The same applies for MRD at a threshold of 10 to the 6, quadrupled for the DRR. PFS favored DARA-LEN maintenance with 30 months PFS of 83% and a 47% reduction in the risk of progression. So I really believe that the results support the addition of daratumumab, not only in induction and consolidation, but also to standard of care lenalidomide maintenance.
So, in your own practice today, how do you approach maintenance therapy? Do you do lenalidomide, daratumumab? Do you give proteasome inhibitors to anybody? How do you approach your own off-trial patients?
A lot of very high-risk patients that received, let's say, VRD plus DARA induction, and they still have residual disease after transplant, I usually introduce carfilzomab with lenalidomide for 18 months, followed by lenalidomide alone if they achieve a good remission. If the patient has achieved a deep response and they are a good risk patient, we still have residual disease after transplant, I do not give consolidation treatment, especially if we're using quadruplet upfront, but I will seriously consider adding daratumumab to lenalidomide as maintenance, even if the patient have received daratumumab during induction. Because I think, yes, our study did not address that particular subset, but I think the Griffin trial and the Perseus trial clearly show benefit for continuous DARA lenalidomide in patients who receive DARA upfront. It's not the clean second randomization to give us the exact benefit of the addition of DARA on those who receive DARA upfront, but I think the data points to improvement in MRD negative rate, and I think it's worth trying, especially if the patient is willing and able to tolerate treatment. That being said, the standard of care for maintenance today is lenalidomide alone, but I think we are moving to doublets, especially in high-risk patients. If the patient is high risk and they are doing well on DARA-LEN, I continue DARA-LEN until progression. I do not stop it, even if they are MRD negative. If the patient is standard risk and MRD negative, after 3 years, the patient is tired of maintenance and seeing me every month, then I will discuss with them seriously, or good risk patient, can we stop the treatment? And some patients will say, yes, I would like to stop. Some people say, no, I would like to continue, and we follow patients. I did not mention the second primary malignancy, which occurred at 7% in the DARA Revlimid arm, and I believe 3 or 4% in the lenalidomide arm. Most of it was actually hematologic, was mostly skin cancer, which has been reported before with the DARA treatment. But I think the increased percentage is related again to longer exposure time rather than to actual increased risk.
And so, obviously, the primary endpoint of your study was MRD, and MRD is obviously an emerging endpoint. Do you routinely monitor for MRD post-transplant?
We are starting to do more and more MRD testing. At this point, we do it only on clinical trials routinely for every patient, as you can imagine. But I think with the introduction of CAR T therapy and the deep MRD negativity in almost 60-70% of the patients, we started to do more MRD testing. And the good news for patients is if you look after transplant, when we screen patients, we screened almost 452 patients on this trial. We enrolled 200 because 100 probably 120, if I remember correctly, were MRD negative just by receiving VRD followed by transplant. If you add DARA to that, your MRD negativity rate is approaching 55, 60% before maintenance. So you are really talking about a very important endpoint today, especially in standard risk patients. So I think as time goes by, we will learn that MRD is going to be not only prognostic and predictive of overall survival, survival endpoints like progression-free survival, but also it's going to be guiding initiation and stopping therapy, especially maintenance in myeloma. Not from our trial, but from other trials, you know that any difference in MRD negativity of about 12.5%, I believe, lead to a difference of about 9 months in PFS. Again, I apologize for the numbers if they are wrong, but I believe that's an accurate assessment. This was meta-analysis done and published within a year in Blood. You might want to check the number. I cannot recall.
Sure. Oh, well, I really want to thank you very much for taking the time to educate the audience about this trial, this large phase 3 study that you led and presented. And I'm grateful for you for taking the time to come on to the program and talk about the trial. And I hope I can turn to you in the future for other topics as well.
I appreciate the opportunity, Vij. Thank you very much.
Thank you.